Okay, guys, let's start. And since it's general surgery based class and my notes and my points, I made sure that I covered the concepts as well as most of the points, important points which can come as an appear as an MCQ in your exams from subsystem, from the common general surgery textbook, which you have to follow in your curriculum. Fine. Fine. So first, let's start with anatomy of the pancreas. So as usual, pancreas is a retroperitoneal organ, okay, situated in the retroperitoneal organ, which in the C loop of duodenum. Fine. And so what is the weight of the pancreas? It's around 75 to 125 gram, measuring about 10 to 20 centimeter. And usually it lies in front of the L1 and L2 vertebra. Fine. And how is the pancreas divided? It's divided into 4 parts: head, neck, body, and tail. So the part of the pancreas which is just overlaying the superior mesenteric vein. So this is the superior mesenteric vein. Here behind the pancreas, the splenic vein joins the superior mesenteric vein and forms a portal vein. So the part of the pancreas which overlays the SMV portal splenic vein confluence and the portal vein. So this part of the pancreas is called as neck of the pancreas, and proximal to it is the head, and then comes the body, and the tail of the pancreas is present towards the splenic hilum. Fine. So the weight of the pancreas is around 75 to 125 gram. Length is 10 to 120 centimeter. And pancreas being a retroperitoneal structure, it lies over the L1 or L2 vertebra. Okay. So the blood supply of pancreas. So pancreas receives a dual blood supply. It receives blood supply both from the cilia as well as SMA, superior mesenteric artery blood supply. So how does it receive from the celiac axis? Basically, the head and uncinate process. The head and uncinate process receives blood supply from the pancreaticoduodenal arteries. So what are these branches from? The anterior and the posterior superior pancreaticoduodenal arteries is branch of hepatic artery, which is in turn a branch of celiac axis. Whereas the anterior and posterior inferior pancreaticoduodenal artery is a branch of SMA. So this is what you can see in figure. So this is the celiac axis. So this is a celiac axis. So in the celiac axis, you can see the 3 main branches. One is the left gastric, this is splenic artery, and this one is the hepatic artery. As you trace the hepatic artery goes have an horizontal course, then it takes an upward course to form a proper hepatic artery. And below the common hepatic artery, it gives this branch. This branch is the gastroduodenal artery, which is a very important branch which gives blood supply to the pancreas, as well as a very important branch which which will be encountering during the any surgical procedure on the head of pancreas. Okay, so this is a gastroduodenal artery. This gastroduodenal artery in turn will branch into a pancreaticoduodenal artery, both anterior and posterior superior pancreaticoduodenal artery. Whereas the inferior pancreaticoduodenal artery is this one. The inferior pancreaticoduodenal artery, one anterior branch and one posterior branch, is a branch from the SMA. So we have anterior and posterior pancreaticoduodenal and anterior and inferior pancreaticoduodenal, which are branches of celiac axis and SMA respectively. So whereas the neck, body, and tail is supplied by the splenic artery, which is in turn a branch of celiac axis. So this is what the blood supply of the body and tail of the pancreas, it comes from the splenic artery. In this branches to the pancreatic branches of splenic artery, one of the branches is very large, which is called as dorsal pancreatic artery. So this branch is a dorsal pancreatic artery. The large pancreatic branch from the splenic artery is the dorsal pancreatic artery, which in turn runs along the inferior border of pancreas to form the inferior pancreatic artery. This is the inferior pancreatic artery. Okay, so just remember the pancreas has a dual blood supply, both from the celiac axis as well as from the superior mesenteric artery. Fine. So as far as venous drainage is concerned, the venous drainage, like in any other organ, it follows the arterial blood supply. So as I told before, that there are 2 anterior superior pancreaticoduodenal artery. Same, there are superior pancreaticoduodenal vein, which is one is anterior and one is posterior. So what happens? The anterior superior pancreaticoduodenal vein joins the right gastroepiploic vein. Why it is important? Because when you're in the initial step of the Whipple's procedure, we have to tackle the venous trunk which drains the pancreas, which is the gastrocolic trunk. So let's see this anatomy. So what is this anterior superior pancreaticoduodenal vein? Most of the time, this anterior superior pancreaticoduodenal vein, it joins. So this is the anterior superior pancreaticoduodenal vein. So this joins the right gastroepiploic vein and the right colic vein and forms a gastrocolic trunk. This gastrocolic trunk will drain into the superior mesenteric vein. So this is very important because for the mobilization of the head of pancreas, the initial step is to find out this gastrocolic trunk and ligate before proceeding for mobilization for Whipple's procedure. Fine. So remember this right gastroepiploic vein joins with the anterior superior pancreaticoduodenal vein and the right colic vein to form the gastrocolic trunk, which drains into the SMV. Fine. So the posterior superior pancreaticoduodenal vein joins SMV directly. So this is again given in this picture. You can see this picture. This is the anterior superior pancreaticoduodenal vein. What happens? It joins with this right gastro. The stomach is being lifted up. See, the stomach is lifted up, and you can see the right gastroepiploic artery and right gastroepiploic vein. So what happened? You enter the lesser sac, and once you enter the lesser sac, you lift up the stomach, and you will find the pancreas. So the stomach is lifted up, and you can see RGEV, that is right gastroepiploic vein, and RGEA, right gastroepiploic artery. So both this right gastroepiploic vein, you concentrate now, it comes down. As it comes down, it joins the anterior superior pancreaticoduodenal vein, and these two main branches form. This is the gastrocolic trunk, which drains into the SMV. So this gastrocolic trunk is also called as Henle's trunk. Okay. So this is one important branch, a venous branch, which you must ligate. Otherwise, the inadvertent injury or slippage of ligature from the gastrocolic trunk might result in massive hemorrhage, and it will make the field messy before the neat pancreaticoduodenectomy. Okay. At the same time, there are two anterior inferior pancreaticoduodenal vein, both anterior and posterior, which joins SMV at the inferior border of the pancreas, fine, like the arterial branches. So as usual, what I said before, the gastrocolic trunk, the most common type of venous trunk is basically gastro-pancreaticocolic trunk, means it has three branches. What are the three branches? As I said before, one is the right gastroepiploic vein. This next branch is the pancreatic branch, which is the anterior superior pancreaticoduodenal vein. And sometimes in some patients, it also has the superior right colic vein. So these are the three most common branches which form the gastrocolic trunk or the Henle's trunk. So what are those branches? One is the right gastroepiploic vein, ASPDV, anterior superior pancreaticoduodenal vein, and the superior right colic vein. These are the three branches. The trunk of Henle is a very common variant in anatomy with the portal circulation. It's a highly variable vessel, but the most common type is what I described before. It is shown in this diagram. That is the combination of the right gastroepiploic vein coming from above, the anterior superior pancreaticoduodenal vein, and the superior right colic vein. All these three forms a small trunk, gastrocolic trunk, and drains into the SMV. And this is the most common anatomy of the gastrocolic trunk or the Henle's trunk. Fine. Can I go ahead, guys? Are you there with me? Hello.
Yes, sir.
Yeah, fine. Okay, fine. So let's start with the pathological conditions of pancreas. First, let's start with the benign condition, the most important condition which you might have routinely and very commonly encountered in your practice during your MS training is acute pancreatitis. So I'll just brush through fast. I'll concentrate on the points which you have to remember as far as the MCQ points are concerned. So what is acute pancreatitis? You all know acute pancreatitis is basically an injury to the pancreas and results in destruction of the acinar components. And how it is clinically characterized? It is characterized by typically an abdominal pain, which is basically an epigastric pain related to the back, which you all know very well, and with elevated levels of pancreatic enzymes. What enzymes are elevated? You are very well aware of it. It's the amylase as well as lipase. So most patients develop a mild and self-limited course, but only 10 to 20% of patients have a rapidly progressive inflammatory response associated with a prolonged length of hospital stay and significant morbidity and mortality. Fine. So what is this morbidity and mortality for an acute pancreatitis? In a mild pancreatitis, the mortality is less than 1%, whereas in a severe pancreatitis, the mortality is 10 to 30%. And what is the mortality due to? So the mortality in the first 2 weeks is always because of an exaggerated inflammatory response causing a multiple organ dysfunction syndrome, MODS. Whereas the mortality after 2 weeks, the person who survives the first 2 weeks might go sick again after 2 weeks because of septic complications. So these are the most two important cause of mortality, which has a bimodal distribution. The first 2 weeks, the mortality is because of multiple organ dysfunction, and the next 2 weeks, the mortality is mostly because of a septic complication. Also remember, in a severe pancreatitis, the mortality rate is 10 to 30%, whereas in a mild pancreatitis, the mortality rate is less than 1%. So these are the things which are given in Sabiston. You better remember this. Okay, mortality in the first 2 weeks is MODS. Mortality after 2 weeks is because of a septic complication. Fine. So what is this etiology? There are varied causes for acute pancreatitis, and the most two important causes in Indian scenario is alcohol-induced pancreatitis. Whereas if you compare the Western literature, the most common cause of pancreatitis, they will say it is biliary pancreatitis, and alcohol comes as second cause. Whereas in Indian scenario, ethanol comes the first most common cause of acute pancreatitis. So whatever is the cause, whether it is ethanol or gallstone or the ERCP induced or drug induced or anatomic obstruction or idiopathic or autoimmune pancreatitis, all causes pancreatic injury, and the initial inflammatory cytokine which is released stain of alpha and IL-1. So that will initiate an inflammatory cascade, and all the cytokines like IL-2, IL-6, 8, 10, bradykinin, platelet activating factor, all gets exaggerates the inflammatory response. And if it's not getting controlled, it results in SIRS and MODS, and ultimately results in mortality. So what happens? All these enzymes in the pancreas are present in an inactive form as a zymogen granules. So what happens because of all these trigger points of pancreatitis? The zymogen granules combine with the lysosomal enzymes which has cathepsin B present in the lysosomal enzymes. This cathepsin B present in the lysosomal enzymes activates the trypsin and causes the acinar cells to release TNF alpha and IL-1, which will initiate the inflammatory cascade. So once the inflammatory cascade is activated, it's self-limited in 80 to 90% of patients, and only around 10 to 20% of the patients will have a severe course. Fine. So basically, any cause, whether it is gallstones, ethanol, ERCP, and whatever it is, it initiates a pancreatic injury by releasing the co-localization of the zymogen granules, which contains the inactive enzymes with the lysosomal enzymes. Lysosomes contains the cathepsin B. So this will activate the inactive trypsinogen into trypsin, which will destroy the acinar cells. The acinar cell, once it gets injured, it releases the inflammatory cytokine TNF alpha and IL-1, and it initiates the inflammatory cascade. And the end result is most of the patients, around 80 to 90%, it will form a self-limited course, whereas it will form a severe course in the remaining. Fine. So etiopathogenesis, always remember, most of the cases which you have encountered in your routine practice would have been because of either gallstones or alcohol. 80% of all acute pancreatitis cases. Remember, the Western scenario, biliary pancreatitis is the most common. Alcohol is the second most common. That's why in Western, they give alcohol as the second most common cause of acute pancreatitis, whereas in Indian scenario, you see alcohol more frequent. So what is the most common in a pediatric patient? Is either due to a trauma or because of any systemic illness. Fine. So in women, what is the most common cause? Definitely, it is because of a gallstone pancreatitis. And alcoholic acute pancreatitis is most common in middle-aged men. Okay. About 30% cause is not known. They are attributed to idiopathic cause. And 10% are because of causes like hyperlipidemia, hypercalcemia, can be drug-induced. It can be post-viral sequel. It can be malignancy. Malignancy, though it is very rare, it is also postulated as one. Iatrogenic, mostly because of an ERCP-induced pancreatitis. Fine. So first, let's talk about this biliary or gallstone-induced pancreatitis. So it's most common in a middle-aged women who are more prone for gallstone disease. And what are the two theories which are proposed for gallstone pancreatitis? One is obstructive theory and reflex theory. What is this obstructive theory? Basically, the pancreatic injury is because of excess pressure inside the pancreatic duct because of the blockage of the pancreatic duct. What is reflex theory? What happens? The stone, once is impacted in the ample of water. So here comes a bile duct. You have a pancreatic duct, and you have the ampulla through which it opens into the duodenum. So in obstructive theory, what happens? There is an obstruction in the duct, which results in ductal hypertension, results in the pancreatitis. Whereas in reflex theory, what happens? There is a stone which gets obstructed in the ampulla here, and what happens? This bile salts present in the bile duct gets refluxed into the pancreatic duct, and it causes damage to the pancreas, initiating pancreatitis. So how do you diagnose acute biliary pancreatitis, and how do you differentiate it from other pancreatitis is very important. So first thing is the patient will have typically an history of a biliary colic. What is biliary colic? It's a constant right upper quadrant pain, which radiates to the inferior angle of the scapula or the right shoulder, and which is usually present in the right upper quadrant, and it's exaggerated by a fatty meal. Okay. And usually it lasts for only 4 to 6 hours. If it lasts for more than 4 to 6 hours, biliary colic, it becomes acute cholecystitis. Fine. So the specificity of, so one is the nature of the pain, biliary colic, and though it is a colic, the biliary colic is not an intermittent pain; it's a continuous pain. Remember that. And the specificity of a serum ALT. So in biliary pancreatitis, the serum transaminase, especially the ALT. So ALT is elevated in biliary pancreatitis. So what is the level cutoff for it? The cutoff is 150 international units per liter for diagnosing gallstone pancreatitis. Fine. So the specificity of ALT level of more than 150 international units per liter for diagnosing gallstone pancreatitis is 96%. Though sensitivity is only less. Okay. So so the typical nature of pain, the presence of altered liver function, especially the ALT levels of more than 150, along